Hello, and welcome to the Physical Therapy Owners Club podcast. I'm your host, Nathan Shields, and today we've got longtime friend and returning guest, Dr. Dimitrios Kostopoulos. He is the chairman of the board, got to get that right, chairman of the board of Hands-On Diagnostics and co-founder of Hands-On Physical Therapy and EMG testing in New York. Dimi, it is great to have you back. Thanks for joining us.
Thank you, Nathan, and thank you for bringing me back, and thank you for everything that you are always doing, helping our profession to get the information that all of us need to improve the conditions for our profession and our lives too.
Right. I always consider you, if people don't know much about Dimi, you can go back to our previous discussions. I think we've had you on the episode or on the podcast maybe 4 or 5 times by now. And if you can tell by his accent, Dimi's not from here, but I consider him the Greek freak of physical therapy. He has had all kinds of leadership positions and has all kinds of relationships and an amazing network in the physical therapy industry. He knows everybody and has had a little bit of influence on everything. So go back and listen to those previous podcast episodes. But today we want to talk about some, how would you describe it? Concerning data that has come out from recent PPS/APTA KPI studies from the respondents that at least turned in their information, because there's a concerning trend that's happening since 2022 and into 2023.
Yeah, you see, before even I go to that, I want to mention that we see that in a much larger scale now, insurance companies complicate the physical therapy processes, especially when it comes to reimbursement, with obviously purpose to manage to deny claims, ask additional information, and prolong paying for these claims, because the longer, of course, they keep their money, they can take this money, put them now in high yield money market accounts. They can put them in high yield US treasuries. So guess what? If they pay you 3 months later than they are supposed to pay you, they have already gained 5.5% in a 3-month US Treasury bill that they buy for millions and millions of dollars. So they end up making a lot of money like that. So the hottest news of the press that we received, both from APTA headquarters as well as from PPS APTA, is the new development with United Healthcare. United Healthcare released a bulletin through which they require, number one, time in and time out from patients to specifically indicate when the patient arrives in the practice and when they leave. Number two, they require very specific now information to be listed in the notes, in the initial evaluation and reevaluation, which is not that bad, okay, to list that information. But the most important part, which has significant consequences, is the fact that they are now requesting for the provider to get a signed plan of care before they see the patient. Ooh. Now, I'm not talking about Medicare plans. I'm talking about general, commercial, United Healthcare, and Oxford plans. They started requiring now a signed plan of care before you see the patient. Now, what this does, it negates right away what physical therapists have accomplished the past decade, which is direct access. Because if you have a requirement for a signed plan of care, right away, they are denying us direct access. Of course, the only reason why Medicare still requires a signed plan of care in order for you to start physical therapy is because direct access is not applicable yet to Medicare. Medicare is not recognizing physical therapists as direct access providers. So that's why they require the signed plans of care. But we have made significant strides in the past decade across the whole country, winning state after state after state direct access, which now is being threatened because of this situation. At the same time, I must add that both APTA and PPS-APTA, they are in negotiations and conversations with United Healthcare to try to reverse this new development. So, but that's very interesting.
Yeah, it's really disappointing simply because I know third quarter profits that United Healthcare posted were somewhere around $25 million.
Make it a B.
In a singular quarter. And they're making it more difficult to pay us pennies on the dollar. So it's difficult to swallow that. And the question I have at this point, because we've addressed it a few times in this podcast over this year specifically, about dropping some insurances, you hear information like that, and you hear about the profits that they've made and how they're going to make it more difficult for us. And they haven't increased flat rate payments for decades in most situations. What is the reasoning behind even keeping that insurance plan at this point?
I think that every provider must sit down and make a very important evaluation in regard to their cost per session. Then evaluate how they treat and deal with each insurance carrier. And I will tell you something that we have done in our practice. And although our practice is, most of them are in New York State, which is one of the states with the lowest reimbursement, at this point, we are in the upper percentile of average reimbursement per session. We have increased, Nathan, our reimbursement from the $60-65 up to, at this point, mid-90s, which is a very significant increase in average reimbursement.
50% increase.
That's right. And I will tell you how we did it. Okay, so obviously there are two ways that we implement it. You know our involvement with Diagnostics, and I'll talk a little bit more about that at the end. But what we implemented was a establishment of 3 tiers of insurance: Tier A, Tier B, and Tier C. So the first thing we looked at was what is our cost per session. So we established that first. Then we went and identified what is our reimbursement rate per insurance. So now, yeah.
Can I ask you what your cost per session is? Are you willing to share?
It has varied from time to time, but I will tell you that our cost per session right now is in the mid 60.
Yeah. Okay. If I were to guess, that's about right, and I would think that's about average, maybe even across the country. Of course, it depends on demographics and salaries and whatnot, but even in Arizona, quite a distance from New York and different payer mix, whatnot. I believe that we were losing money on that $65 flat rate payment that United Healthcare provided us by about $3 or $4 a visit. And I don't think I'm far off if I said that most of the industry is somewhere around there, maybe even into the 70s a little bit.
Yeah. I think we are in the low 60s, maybe 62, 63, somewhere around there right now.
Sure.
But here is what we did. Insurances that would pay us, more than one standard deviation above our mean. So I would say I will calculate, let's say, what our mean is, and then what's the standard deviation. And if an insurance, for example, would pay us $80+, that insurance, I would put it in tier A. Okay. Then I would have insurances that are, just above the mean as tier B, and insurances that are hovering at the mean or below, I would put them on tier C, knowing that if I see that insurance, either I break even or even maybe I will lose a little bit of money from that.
Well, you're not making a profit.
I'm not making a profit, exactly.
Right.
So now, what was the mechanism with this? Obviously, as an ethical business, we did not discriminate. We did not say, okay, if we accept the plan, we have to see a patient.
Right.
However, what we did was this. We identified what percentages we got of tier A insurance from referral sources or other avenues of marketing. So if these 20 physicians, 30 physicians, 50 physicians who refer patients to us, their patients, the preponderance of their patients tend to be, that they refer to us, tend to be tier A, we intensified our marketing to those physicians.
Mm-hmm.
Then we looked at what is our marketing strategy, social media, direct-to-consumer marketing. So we identified, okay, what age populations, what specific demographics, what financial brackets of people, what areas of that people live would give us the most tier A referrals, the most tier A patients, and we loaded our marketing towards those areas. So what happened then, instead of having the vast majority of patients either tier B or tier C, we started having the vast majority of our patients, like 75% of our patients, 80% of our patients on tier A, and then the remaining patients are tier B and tier C. Okay, that's something interesting, and that's how we increased significantly our revenue per visit. Okay,
is that something then, the transition from 60 something dollars on average to greater than 90, what was that time frame? How long did this take you?
You know what, it did not take awfully long time, but I would say just a bit over 6 months. That
nice.
The conversion was made.
So you didn't drop any insurances at all.
No.
You were simply focused on
right.
marketing efforts only on those higher payers. And did you essentially eliminate marketing towards the tier Cs then?
Exactly. Eliminate marketing, or a patient would have to wait, let's say, for 2 weeks before they came in, because simply our schedule was full. There was no availability. But a physician, let's take an example, Dr. Smith, right, who sends to us, let's say, 80% tier A patients and 2% tier C patients, let's say, right? I don't want to go through the process where I say, hey, Dr. Smith, by the way, we no longer accept this plan or that plan or the other plan, because I don't want to disappoint them. Instead, I will continue seeing those 2% of tier C plan patients, but maybe they'll have to wait longer to get into the schedule, especially if all of our marketing fills the schedule with tier A patients.
Right.
So naturally, it's a natural change that happens in the practice then. So you don't do anything unethical or something. It's just that you see the numbers changing because of where you put attention on.
Right. And would you give those tier A patients preferred eval times? Maybe they can get in a little bit faster than the other tier C patients?
Not necessarily. There was no, we did not want to follow a discriminatory policy in our practice, but naturally, because of our marketing efforts. So you see, if there is a physician who sends you tier C patients and you stop going to visit them, some other physical therapist will go visit them and they will start sending patients to the other physical therapist. So I am very happy if other physical therapists are very, very busy with tier C patients. I have no problem with that. But in our practice, we do anything possible to get more tier A, tier B type of insurances.
So it was all about your intention with your marketing strategy. Number one, you had a marketing strategy, or at least you had some marketing efforts happening, right? And then taking that marketing strategy and pouring gasoline over on this section and not just the whole thing. And it's not a matter of volume at that point to everybody, but volume directly, specifically focused to those to that tier A demographic.
Yeah. And correct. And Nathan, anybody who is listening to this, I want to caution them on how they calculate that. Because it's not simply enough to say insurance A pays me this much of money more than insurance B, right? Let's say that insurance A pays you $100 and insurance B pays you $85, right? Now, naturally, you may think, okay, I will take more insurance A patients instead of insurance B. Well, I encourage you, instead of looking only at reimbursement from insurance A per session, I encourage you to look at reimbursement per minute. Reimbursement per minute. You heard me right. Why? Because there are insurances that they would pay you $100, but their policy and requirement is for you, in order for you to make $100, you have to be with the patient one-on-one 100 minutes. Let's say I'm trying to make it simple, right?
Right.
And you have another insurance. So then we're making $1 a minute. Let's say you make $100 for 100 minutes, that's $1 a minute. Then you have another insurance that pays you $85. But let's say the legal requirement to the time spent for that patient is only, let's say, 30 minutes. When did you make more money? I have my calculator here. So 85. No, I'm going to do that because I'm going to give you the number right away. So 85 divided by 30, that is now 2.83. So you made
$2
almost 3 times as much from that patient, despite the fact you got paid less, so you can fit more patients.
Yes, I see.
You see?
Well, as you're doing these calculations, you have to be, was there any preparatory work done in terms of, were you confident, did you trust that your providers were billing the maximum amount for the therapist, for the services they provided? So one of the issues I see commonly with clients that I work with as a coach is that their therapists are underbilling. And that's the tendency for most physical therapists. I like to call it compassionate billing. If they're going to go one way or the other, they're not going to try to maximize and document for all of the services they provided. If there's a question at any time, they're going to cut the units down and get paid less. Was there any work done beforehand so that you could trust that, number one, you were, that you were actually billing for everything that you could maximally?
Yeah. Obviously, this is an internal issue issue, internal systems issue that needs to be corrected in a practice. And even when you correct it, you cannot just let go. You have to continuously look at improving conditions in regard to that. So it has to do with education and
Right.
culture. All right. So, I definitely, I do not want unnecessary codes done, unnecessary billing done. I'm not talking about overbilling.
Sure.
However, I would like therapists to, and we try to educate therapists to bill for all the things that they do. Because you know what happens, Nathan? Therapists, it's not that they don't do enough stuff. They just don't code right, and they don't interpret right what they do in order for them to bill it. It's not a matter of them doing the right thing or not for their patients. They do, the vast majority of therapists do the great things for their patients. It's just that they are not educated enough on how to write that in a proper manner. Okay. So if you take, for example, a specific exercise that has a, let's say, a balance and proprioception component, and you end up billing it with 97110 as if it was therapeutic exercise, which you're going to bill with anything else, instead of billing it for 97112, well, it needs education there.
Right. Exactly.
So, and it's not education only selecting the proper codes, it's education also on how to phrase, how to write the note of what you are doing and how you document it properly.
And that's why I liked the conversation I had, I think it was a few episodes ago, and I know you shared it with the hands-on diagnostics community with Prediction Health, how now there is an AI system that can teach your providers how to document appropriately for specific exercises and code them appropriately. So as you went into this effort to see, okay, what are my tiers A, B, and C? You had a culture, you had confidence that your providers were billing well. You had provided that education. They knew the difference between certain codes and how to bill and document for them correctly. They also knew the difference between AMA versus Medicare billing rules.
Correct.
So that was all already understood. And I fear that some listeners might look at this, well, like, I just need to get into DME's, follow DME's program and find my tiers A's, B's, and C's without doing that initial work. Because I think there's a lot of money. Well, I know there's a lot of money left on the table, probably at least a 10 to 20% increase in revenues and profits if they simply did that pre-work in coding, billing correctly.
And if you don't mind, Nathan, I would like to share, and I'm going to share it. Those of you who are watching on Zoom right now, I would share my screen with the KPI numbers that we're talking about.
Right.
And this is from the latest KPI study of PPS APTA for 2022. And definitely big acknowledgement to PPS APTA. And I encourage every single person who is attending right now, not only for you to become a member of the APTA and the private practice section of APTA, which provides huge, amazing resources for your marketing and education on how to successfully run a physical therapy private practice, but also I encourage your participation to the annual key performance indicator data that provides you not only KPIs for the entire nation, but also it compares your individual data with your regional and national data. But you can see here, for example, and we're going to focus on the average and the median, right? You can see here that in terms of visits per new patient, the vast majority of practices, they are doing about 12 12.1 to 12.9. The average is 12.9. They do around 12-ish, 12 to 13 visits per new patient.
Right.
And what you were saying before is important. They are doing 3.6 to 3.7 procedures per visit. This would be your units, essentially, about
Right,
3.7 units per visit. You can see here that for 2022, the median revenue per clinical hour was about $108. That's the median. However, the cost per visit, this is national average, cost per visit, $91.59. Now, this resulted to only a net income of 7.2%. That was the median. The median was 7.2% net income.
That's a horrible profit margin. I mean,
that is a horrible profit margin.
You don't want to be in business at 7%.
Absolutely not, because a hiccup from Medicare, a sneeze from United Healthcare, and all of a sudden you are in a negative territory. So that is a big problem. And you can see here that practices who were on the 75th percentile and above, they had a better number, about 15.9, 16% of profit margin, and practices on the low percentiles, they were down to 1.8%. Now, if you remember, last year, like the whole 2021 and part of 22, whenever I came to your show or I gave other webinars, I was always discussing the whole situation about Medicare and the changes in reimbursement models and the reductions of Medicare and other insurance carriers that followed reductions. And here is what I'm going to share with you, which is very staggering and worrisome. So I have here the net income history nationwide from 2016 to 2022. And look at this. In 2016, it was 13.6%. Yes, I understand that in 2017, it went to 10.6%. But then let's look at 2018, 2019, and then 2021. 2020, there was no study done because of the pandemic. So 2018, 2019, and 2021, the net profit was averaging about 12.5%. And look what happened in 2022, 7.2%. We had a drop of 5 percentage points. If you multiply that to what it represents in terms of actual dollars, it is very, very significant. So, and this is why it is very important for physical therapists to make the right choices about what insurances they accept, to make the right choices about what patients they accept, what billing their staff members are doing, but also looking at how to expand in other practice areas that can be significantly more profitable than just their PT. Okay.
Yeah, it's a disturbing trend, of course, because you would imagine there were between 100 to 200 respondents in the survey, right? And you would imagine that those are probably on the better owners.
The cream of the crop. The cream
right?
of the crop. Exactly.
Like the numbers are probably skewed in a positive direction because of the surveyors that are actually turning in data. The ones who don't have good numbers are probably embarrassed and don't have the time or too busy to turn in that data. So they're probably skewed upwards, firstly. Second, I was way off. I thought maybe $70 per visit, cost per visit would be a national average. Obviously, that data shows me it's $90 to $100 per visit. Even the 75th percentile clinics, I noticed on their average cost per visit was over $100, but they combat that with getting revenues that are averaging, I don't know, 100 and I didn't see what it was, $114 per visit or something like that.
Yeah. And you can see even in 2023, okay, if you see the first quarter financials that were released with some of the big physical therapy publicly traded companies like APTA, USPH, you are going to see that some of them had actually negative negative margins, and those who had positive margins, they were like in the 3% or 3.5%, and that is also worrisome. Yeah,
where do you think that's coming? I'm thinking there's just this confluence of issues that are coming down on the physical therapy industry, and we're not alone in that. Whether it is inflation in and of itself, the cost of team members, the lack of physical therapy. Well, there's been a rush out of the industry of over 20,000+ physical therapists from the industry, so it's hard to find a therapist, and if you're going to do so, you've got to pay more significantly. Right. There's been just, and now the insurances are making it more difficult, as evidenced by United Healthcare's stance, that this confluence of issues has just made it more difficult to generate a profit.
Definitely. And I will tell you that one of the bigger problems, on the one hand, you have that reduction of reimbursement, and at the same in the same capacity, you have increase of payrolls. That is a very, very important component. If companies used to spend for payrolls 55, 60, 65%, and right now they end up spending in the mid 70% on their payrolls, that is very significant.
Yeah, 70% of your gross revenue is going towards payroll. That I can see where your profits you get lost essentially.
Correct. And actually, I want to give you some more specific data. The first quarter of 2023 payroll expense as a percentage of income for USPH was 68%. So nearing 70%. Okay. Wow. So this is this is pretty significant.
For those owners who are listening, what we're talking about is a key data point in your profit and loss statement that you might want to review with your bookkeeper or CPA, and that is, and you tell me what your target is for this, but we always, if we could get our payroll numbers, including benefits and pay time off and all that kind of stuff, everything related to payroll, salaries, of course, to 50 to 55% of gross revenues, then we were doing really well. We were generating a nice profit. That was a sweet spot. If you got below 50, you just had an amazing productive month. Yeah. But you aim for 50, 55. And when it started getting pushed towards 60, then we saw a serious squeeze on our profits. Do you see about the same targets for your company?
Yeah, so I'll tell you that when it comes to the retail industry or other non-service to consumer industries, their payrolls are about 33-35%. With the pandemic and all that happened, they went up to 40-42%. Now, in service oriented industry, service delivery is always somewhere around 50+%. Okay, with the pandemic, these numbers went higher. In the physical therapy industry, we've had a massive exodus of physical therapists from the profession. Not enough physical therapists produced every year, and at the same time, a tightening of the immigration policies that allow less physical therapists to come into the United States. So there is a great demand for staff, and payrolls have gone significantly up. You asked for our figure. We are in the first quarter of the Q1 of 2023, we were at 57.16%.
That works.
Yeah.
Right.
Yeah. But this is, our numbers is a little skewed though, because this is, we are 57% payrolls compared to income, to revenue, but our revenue is combined revenue of physical therapy and diagnostic testing. It's not only physical therapy.
Right.
So our average reimbursement is significantly higher if we combine the diagnostic testing revenue together with therapy revenue.
Gotcha. And I want to talk about that, of course, but I also want to highlight with your focus, and you'd started this focus on marketing towards tier A, B, and C a few years ago. Am I wrong? Has it been 2 or 3 years?
Yeah. Yes.
And since doing that, you've been able, or you had a focused expansion strategy targeted around this as well, such that you've opened a number of clinics based on this strategy. Tell us about that a little bit.
Yes. So what we end up doing is, since we had identified those tier A insurances, we then, before opening a new clinic, we started looking at the demographics in specific areas. We were looking at opening clinics to match the demographics of people having the tier A insurances.
Oh, interesting.
So this way, when you open, let's say, a new location, we have two advantages. Number one, the new location is in an area where we're going to have a greater percentage of tier A insurance. And number two, from day one, we implement diagnostics in that new location. So if from day one, my average reimbursement per session will end up being $130-something or $140 per session, if I combine the diagnostic testing and PT, then you break even much faster than if you did it without a strategy, without a method.
Right. Yeah. And I think that's the first, that kind of blew my mind, because that's the first time, number one, that I guess I'd heard about focusing on the higher payers in general. When you talk to small business owners, the importance of focusing on the top 20% that provides 80% of your business, right? But you took it a step further in your expansion, and that's what was mind-blowing to me, is that, hey, this is the demographic and this is where they live. Why don't we open up a clinic over there where we see more of those patients?
Yeah, definitely. I mean, instead of doing things randomly, you can have a strategy, you can have a plan, and implement that plan. So thoughtfully, you take action.
And I have to ask, because I've been a big proponent of simply dropping the lower payers. What keeps you from simply dropping some of those contracts altogether?
Okay. So, and we have dropped some
You have?
payers. We have, yeah. I would say those were payers where they were more than one standard deviation on the left
Below.
or below our mean. Okay, so I'll give you an example. If, let's say, my cost per visit is $62, right? And there is an insurance that will pay me $60 or $58, where, yeah, I know I'm not going to make a profit. I'll make it up from some of the higher plans. But so this insurance, although it's not going to generate significant profit for me, I see that as a investment of the relationships I have with the physicians that I serve, right? And that would be under my tier C category, and I'll see sporadically a few of these patients. So it's not going to hurt me, really.
Yeah.
But if I have an insurance that would pay $34 a visit, and believe me, there are plans that they pay $34 a visit.
Right.
That plan, of course, I'm going to drop it because it will require significant effort for that insurance, such a lower payer, not to hurt me. It will take up too much of the higher paying insurances to make up for the difference. Okay. So, yeah. So that's
what has been your success in negotiating for higher reimbursement rates? Have you gone that route as well?
So we have, but I will tell you, we have not done enough of that. Okay. So I am not going to consider myself an expert on that part yet, at least. And when I have some better successes on this, I will definitely report back to you. I do know a few people who have done that successfully. Right. So we're in the process of working in that direction. Yeah.
And then tell us about when you say adding diagnostics to your care, to your episodes, are you in most situations, are you doing EMG and MSKUS or both? Or,
So here is a general concept, right? Out of 100 patients that you see in a general physical therapy clinic, I'm not gonna say that does not apply if you have a practice that is 90% pediatrics, or it's 90% stroke victims, or something like that. That's not what I'm talking about. I'm talking about your general physical therapy practice, where you have orthopedic, you have pain management cases, you have your sports injuries, and elderly people too. So with that combination, with that general practice, out of 100 patients who come to your clinic, about 70% of them would qualify for you to perform a musculoskeletal ultrasound, whether to look at some muscle or tendon or joint pathology, or neuro ultrasound, where you look at the integrity of a nerve. Ultrasound, on the average, across nationwide average reimbursement for 2 units of that will be about $200, maybe $180 to $200, and it will take you, 15 minutes to perform that. Now, out of 100 patients in your practice, about 35% of them would qualify for you to do a nerve conduction EMG study. Nerve conduction EMG study, national average would be about $500. So you do the math. You have a patient that gives you, let's say, $100 per physical therapy visit, and you do an average of 12 visits. So for 12 visits, you make $1,200, right? Let's say you added 1 extra visit where you did a combination of EMG and neuro ultrasound. in that single additional visit will yield for you $700. So all of a sudden, a patient where you got in 12 visits, $1,200, meaning $100 per visit, now for 13 visits, you got $1,900, which represents $146 a visit. Here, I did the math. It's for those who watch. So there's a big difference there, right? So your average reimbursement goes significantly up with the incorporation of diagnostic testing. So it is at this point our model that we are not opening new physical therapy practices unless we are able from day one to implement diagnostic testing in the practice. Simple as that. Because if I implement diagnostic testing, I'm going to be able to break even faster, and I'm going to be able to turn around and make a greater profit faster. Simple math.
And what's the trend that you see with musculoskeletal ultrasound? Because as someone who knows the diagnostic side of things quite a bit, the barrier to entry for EMGs can be difficult. It's not easy to become ECS certified as someone who's been through it. But musculoskeletal ultrasound has a lower barrier of entry. You can do it. You can implement it faster. They are faster tests to do in general. I've been saying it for years, and it hasn't caught fire yet, but I think it's starting to in terms of the trend for musculoskeletal ultrasound in a majority of PT practices. What's your feeling on that?
Yeah. So first of all, when hands-on diagnostics was created in 2013, 10 years ago, actually, the first thing we did at the beginning of 2014 was that we ran a nationwide study, nationwide survey, where we surveyed physical therapists around the country about their knowledge, if they knew what EMG was and what musculoskeletal ultrasound was, and if they knew that the PT is able to perform these tests. And guess what? 97% of the PTs, they had no idea about that. Only 3% of the industry knew about that and the ability of PTs to perform that. Well, in September in our HUD symposium, I'm going to announce the outcomes of the new survey we did, the new nationwide survey 10 years later. But I mean, I can tell you that the difference is striking. Physical therapists now, they are a lot more aware about the fact that they can perform these tests and they can get paid. Also, well, first of all, I mean, let me just say congratulations also for Casey, your associate there, who just became board certified in EMG. That's fantastic. You've been board certified in EMGs now for several years. That's awesome. But musculoskeletal ultrasound can be learned very, very easily. I mean, hands-on diagnostics has a fellowship in musculoskeletal ultrasound, which you can literally complete the fellowship within 6 months, and you do it in your practice. There are 9 days of education that you do it over three-day weekends, and then mentorship and reports that you do with the help of a mentor. So it is very natural for a physical therapist with the knowledge they have of anatomy and all that to navigate towards musculoskeletal ultrasound. And we see also that APTA and PPS APTA, they're embracing more and more the performance of diagnostics by PTs. And I believe it's very soon that it will be just one of the gold standards within the physical therapy industry.
Yeah, I like to compare it to dry needling, where dry needling, what would you say, about 15 to 20 years ago, no one had any clue what it was, and now it's fairly ubiquitous across the industry.
Yeah.
I have a feeling ultrasound could be the same, it should be the same, especially if we want to be a primary care physician or primary care profession.
Provider, yeah. And especially if you consider that you can even do dry needling under musculoskeletal ultrasound as a guidance, and there is a special code that pays physical therapists for the guidance of the needle. So greater accuracy and greater reimbursement too.
Right. One of the things I know that we need to focus on as a profession is getting Medicare to recognize our ability, making that part of our scope. Do you think we're close?
You mean on the musculoskeletal ultrasound side?
Yeah.
So at this point, there is one of the Medicare intermediaries in the country. I think it is Noridian.
It's mine. Yeah.
It's yours, Noridian. You're Noridian, right? Or no,
they'll pay us for ultrasound up here in the West, but the rest of the country they won't. And it's striking as to why. I'm worried that the rest of the country is going to say is going to put pressure on the West for Noridian to not pay it versus Noridian.
Actually,
you guys should pay for it too.
No, actually, quite the opposite happens. Although I cannot speak of information that I know that is more on the APTA side, which perhaps at some point you can have a guest from the Government Affairs Department of APTA to talk about this. But I have to tell you that APTA is in the process of working towards the complete and full reimbursement of musculoskeletal ultrasound by all Medicare intermediaries across the country.
That's good. Well, Dimi, we've spent a ton of time talking about, man, some disturbing trends, but also how to combat them. We're not completely powerless, right?
Of course not. You know, at the end of the day, these insurance companies, they play a game. So in a game, the first thing you need to know are the rules of the game. You have to know the rules of the game in order to play the game right. Every game will have barriers and it will have freedoms too. So both of them are needed for the game of life. So without having some barriers and some challenges, we're not going to have freedoms and we're not going to have wins on the other side. So if you also consider that happiness, at least one of the definitions of happiness is the overcoming of known barriers in life, then hey, we have seen these barriers, we learn the rules of the game, we play an intelligent game too, and we win on the other side, and we're happy.
That's right. Yeah, exactly. Well, thank you so much for sharing your knowledge. Thank you for all that you do in the profession and standing up for it as well, and what you've shared with the community and at large. So what's happening in the near future with you? How can people get a hold of you? Tell us a little bit about that, Dimi.
All right. So what's happening in the near future? The first amazing thing is that September 16th and 17th, we have the 10th annual HUD Symposium. Viewers and listeners can get 50% off the tickets for the symposium. The symposium is physical therapy, a primary care profession, the role of EMG and MSK ultrasound testing. It takes place in the amazing Clearwater, Florida at the Sheraton Sand Key Resort waterfront. Amazing. If listeners go to hudsymposium.com and they plug in welcome 50, they can claim a 50% off ticket. And definitely people can get in touch with me by going to callwithhuds.com, and they can book a meeting with me. And of course, there's a phone number I have also there, 888-447-6014. So This is the contact info.
All right. So thanks for your time today. I really appreciate it.
Thank you too, Nathan. Take care.